Okay, so today we have the GIT non-emergency scenarios for critical care. So this is your first scenario. Kindly review it and then we will start.
Yes. Yes, sir.
Okay, so can you define what is enterocutaneous fistula?
An intracutaneous fistula is a granulation tissue-lined tract which is connecting the bowel, which is the small bowel or the large bowel, with the skin.
What is the classification
Yes.
of enterocutaneous fistula?
The intracutaneous fistula can be internal or external, simple or complex. Um, it could be, mm, uh, yes, sir.
Okay, so what are the predisposing factors which results into formation of enterocutaneous fistula?
It could be any infections, inflammatory conditions like Crohn's disease. Most common causes malignancy. There could be due to anastomosis, um, and can also be due to malnutrition. Yes.
Okay, so can you tell me what are the complications of enterocutaneous fistula?
Intracutaneous fistula complications are there could be an sepsis, distal obstruction, causing a non-healing of the intracutaneous fistula. Then there can be malnutrition, fluid and electrolyte imbalance if there is a high output fistula. Then yes, complications. Yeah.
Okay,
Protein. Yes.
so can you tell me what are the different signs of intra-abdominal sepsis?
The various signs are there could be nausea, vomiting, abdominal pain, abdominal tenderness, rigidity, guarding, hypotension, tachycardia, and fever.
Okay,
Yeah.
so what are the principles of management of enterocutaneous fistula?
The intracutaneous fistula is managed by stabilizing the patient in the initial approach by A, B, C, D, E, and according to the SNAP criteria. So, in the SNAP criteria, first we will assess if the patient is having a sepsis. Then the next thing is nutrition. If the patient is having any malnutrition, we can supplement the patient with total parenteral nutrition. Then we can also check for adequate hydration and fluid and electrolyte balance, and also the regarding the anastomosis, condition of the anastomosis, and also protection of the overlying skin. Then we can also plan for surgery.
Okay, so briefly tell me about the sepsis 6 protocol.
In the sepsis 6 protocol, there are 6 things that we have to give and take. So we can give 3 things, that is the high flow oxygen, IV fluids, and IV antibiotics. The 3 things that we take from the patient are blood culture and sensitivity, blood for culture and sensitivity, then serum lactate ABG, and serum lactate ABG, and uh, urine output. We'll measure urine output. Yes, sir.
Okay, so what are the factors which prevent spontaneous healing?
If there is a distal obstruction, if there is any underlying malignancy, in case of any high output fistula, if the patient is having any chronic disease like Crohn's disease, if there is a malnutrition, the healing is impaired. Yes.
Okay, so what are the different imaging techniques that can help us with the management or identification of enterocutaneous fistula?
Sir, can you repeat the question again, sir?
What are the imaging techniques which can help us with the enterocutaneous fistula?
Yes, sir. We can take the patient for a CT scan of the abdomen involving with contrast to and also fistulogram to look for the extent of the fistula and also the complexity of the fistula.
Okay, so what is the fluid management for a high output fistula?
Fluid management is we can give if there is any electrolyte imbalance, we can correct the electrolyte imbalance because in case of high output fistula, there could be electrolyte imbalance, and we can also replenish, hydrate the patient. Then we can also give the patient total parenteral nutrition until the fistula heals.
Okay, so all of your answers were pretty much okay. So just
Yes,
focus
sir.
more on the management. Okay,
Okay,
you
sir.
have to say the
Okay, sir.
SNAPS protocol and you have to briefly
Okay.
explain the sepsis protocol as well.
Okay, sir. Yes, sir.
Okay, so this is your next scenario. Review it and then we will
Yes.
start.
Okay, sir. Yes, sir.
Okay, so what is the normal level of bilirubin?
Normal level is 3 to 30 micromoles per liter.
And what is the level which is required for causing apparent jaundice?
The level has to be more than 35 micromoles per liter for jaundice to be evident.
Okay, so what type of jaundice will be present in this scenario?
It will be obstructive jaundice due to increased levels of conjugated bilirubin. And should I explain more, sir?
No. Okay, so
Okay, sir.
why
Okay.
clotting factors are deranged in this clinical picture?
Since there is an obstruction, the bilirubin, the bile is not excreted out of the hepatobiliary system. So it damages the liver. The liver are the main area where clotting factors are produced. So this leads to a derangement of the clotting factors, especially the factor 2, 7, 9, and 10.
Okay,
There
so
is also vitamin K deficiency due to malabsorption or decreased absorption of vitamin K from the intestine due to the obstructive jaundice.
which clotting studies will be abnormal,
PTINR, sir.
and how will you correct that abnormality?
We can correct it depending upon the condition of the patient. If the patient needs an immediate correction, we can give the patient prothrombin complex concentrate and fresh frozen plasma. the patient, if we are doing any elective surgery to the patient, then we can go ahead and give the patient vitamin K 10 mg IV OD for 3 days, and followed by prothrombin complex concentrate, then fresh frozen plasma, and also take a hematology consultation.
Okay, so what is alkaline phosphatase?
Alkaline phosphatase is an enzyme produced in the liver, which is raised in certain conditions like um, malignancy, uh, pregnancy, then yes, malignancy, pregnancy, and in case of any spread of tumors.
So what is the function of bile?
Bile emulsifies the fat. It also helps in the absorption of fat from the food.
And how does bile salts help in the emulsification of fat?
The mm, the when the food enters the small bowel, the bile is secreted, and there is emulsification of fat. So the fat micelles, that is small fat droplets, are formed, which has a hydrophobic core and a hydrophilic outer layer. And this helps in increasing the surface area for enzymes, the pancreatic lipase enzymes, to act on the fat to digest it. Uh, so hence, the bile salts help in emulsification of fat.
What are the constituents of bile?
Bile contains mainly water, followed by cholesterol, bile salts, bile acids, bile pigments, lecithin, and mm, yes, sir.
And what is the amount of bile that is daily produced?
About 500 to 1000 ml per day in 24 hours.
Okay, so what is bilirubin conjugated to?
Uh, Bilirubin is conjugated to bilirubin glucuronides with the help of glucuronidase enzyme in the liver. Uh, should I explain more, sir?
Yes, tell me about the metabolism of bilirubin.
Yes, sir. So the heme, the red cells are broken down to release heme, which is acted upon by the biliverdin to form bilirubin. This is transported to the liver with the help of the albumin or binding other binding proteins. Then in the liver, the glucuronidase enzyme acts on the bilirubin to form bilirubin glucuronidase, hence conjugating the bilirubin. The conjugated bilirubin enters the small intestine via the hepatobiliary system, and it is getting converted into urobilinogen with the help of the colonic bacteria. uh, and the urobilinogen is also converted into stercobilinogen with the help of the bacteria, and 95% of the urobilinogen is reabsorbed by enterohepatic circulation from the terminal ileum. A small amount of it gets excreted in the kidneys, giving the urine a color, the characteristic color of the urine. Then the stercobilinogen gives the characteristic brown color for the feces, which is the byproduct of urobilinogen.
Okay. So can you explain what is enterohepatic circulation?
Enterohepatic circulation is a circulation where the bilirubin is urobilinogen is absorbed from the terminal ileum, and it directly enters the liver, so that the liver doesn't have to produce extra bilirubin again and again because 50 percentage of the secreted bilirubin comes back via intrahepatic circulation.
Okay, so why in this scenario urobilinogen was not detectable in the urine?
In because since this is an obstructive jaundice, the bilirubin will not be secreted into the bowel to convert into urobilinogen. Hence, so then the urobilinogen gets absorbed via intrahepatic circulation and gets excreted in the urine. Some amount get excreted in the urine. So since there is obstructive jaundice, this cycle will not happen, leading to absence of urobilinogen in urine.
Okay, so what investigations you will do in this scenario?
Uh, since the patient is having a right hypochondriac pain, initially I will do a liver function test and then I will go ahead with ultrasound scan to look for the diagnosis if there is any dilated hepatobiliary tract or if there is any pericholecystic collection or presence of any stones or thickening of the gallbladder.
Okay, so if you find a CBD stone, what will you do?
If CBD stone is present and if there is a dilatation of the and hepatobiliary tract, then we can go ahead with ERCP because ERCP serves as a diagnostic and therapeutic tool. So hence we can do a sphincterotomy and remove the stone from the biliary tract. Hence helping in therapeutic clearance of the obstructive jaundice.
Okay, so if this patient developed fever, pain, and chills, how will you manage it? And what will be your diagnosis?
Fever, pain, and chills could be due to acute cholangitis, ascending cholangitis, or could be due to acute cholecystitis. So, if the patient is having acute cholecystitis, we can go ahead with emergency surgery, or we can do a delayed surgery like within 7, or 10 days. Depending upon the condition of the patient. If the patient is having ascending cholangitis, we can start the patient with IV antibiotics. Then, for pain management, we'll give analgesics. Then, we can also give IV fluid supports. Then, send for liver function test, urea and electrolytes, and also do ultrasound scan. If there is presence of dilated hepatobiliary tract with no stones, we can go ahead with MRCP investigation. If there is presence of stone, then we can go ahead with ERCP.
Okay, so what antibiotic you will give to the patient in scenario of ascending cholangitis?
We can give cephalosporins with metronidazole.
Okay, so
Uh,
uh,
since it covers the causative organisms like E. coli, Streptococcus faecalis, Klebsiella, and Bacteroides.
okay, so give me different types of jaundice with one example each.
Okay. Prehepatic, hepatic, and post-hepatic are the three types. Prehepatic could be due to hemolytic anemia, G6PD deficiency. Hepatocellular hepatic cause could be due to hepatocellular jaundice, alcoholic hepatitis. Post-hepatic jaundice could be due to ileal bypass or any defect in absorption from the ileum, or could be due to any obstruction.
Okay, so classify obstructive jaundice.
Uh, Obstructive jaundice is classified into three types: intramural, transmural, and extramural. Intramural could be due to the presence of stones. Transmural is due to strictures or cholangiocarcinoma. Extramural is due to pancreatic cancer.
Okay. So your answers are pretty much okay for this scenario.
Okay. Okay, sir.
Okay, so next up we have the gallbladder stones. Kindly
Yes,
review
sir.
the scenario and then we will start.
Okay, sir. Sir. Yes, sir.
Okay, so what are the differentials in this scenario?
This is probably due to acute cholecystitis. It could be due to acute cholangitis or ascending cholangitis. This is uh, since it is a right-sided hypochondriac pain.
Okay, so what is the
Yes, sir.
pathogenesis of gallstone formation?
Gallstone is of two types, cholesterol gallstone and pigmented gallstones. Most common is the cholesterol gallstones. Cholesterol gallstone is due to the supersaturation of cholesterol in the bile, then leading to nucleation of the cholesterol, forming cholesterol monohydrate crystals. There will be increased secretion of the mucus in the gallbladder. And Yes, sir. So hence forming cholesterol crystals, crystallization of the cholesterol. Then the pigmented gallstones could be due to any hemolytic anemia, or it can also be due to contamination, bacterial contamination of the biliary tract, or due to any uh, intestinal problems, like ileal bypass. Yes, sir.
Okay, so what are the investigations which are required to identify the pathology in this scenario?
Uh, we should send the patient for LFT, urea and electrolytes. Then we can do the ultrasound. Depending upon the ultrasound, if there is any uh, intrahepatic biliary dilatation, we can go ahead with ERCP or MRCP. If the diagnosis of acute cholecystitis is made, then we can go ahead with elective or emergency cholecystectomy. And if there is presence of stones intraoperatively, we can remove the stones, or otherwise we can do ERCP to remove the stones after the cholecystectomy.
Okay, so patient has no fever, patient is young, and the CBD is clear on the ultrasound. What will be your management?
Uh, so here we can advise the patient to go for elective laparoscopic cholecystectomy. Since there is no fever and the patient is young, we should also counsel the patient regarding the complications. If there is a delay in the laparoscopic cholecystectomy, we can also inform the patient regarding the advantages and disadvantages of performing laparoscopic cholecystectomy.
Okay, so what will you do if you find a stone in a CBD?
During surgery, sir,
Yes.
we can try to extract the stone if possible during laparoscopic cholecystectomy. If it is not possible, then post surgery we can do ERCP and remove the stone. If in ERCP also the stone cannot be removed, then we can do T-tube insertion and drainage of the biliary tract. And once the tract is matured, we can do an MRCP and remove the T-tube to look for
Okay.
obstruction and remove the T-tube.
Okay. So what are the complications of gallstones?
Gallstones can lead to obstruction, cause intestinal obstruction causing gallstone ileus, causing intestinal obstruction. It can also obstruct the common bile duct, leading to intrahepatic biliary tract dilatation. There can also be form rupture of the gallbladder or MRCS syndrome, formation of fistulas. There could be also abscess formation, empyema, and mm, there are chances of recurrence of the stone if the gallbladder is not removed. Yes.
Okay.
And
What
there can also be acute pancreatitis, which is the most common complication of gallstones.
okay, so what are the complications of laparoscopic cholecystectomy?
During the surgery and after the surgery are the two classifications. During the surgery, there could be bleeding due to injury to the bleeding from the cystic artery. There can also be a transection or injury to the CBD causing biliary leak and peritonitis. Post-surgery, the patient can develop post-cholecystectomy syndrome. There can also be scar of stricture formation, DVT, and there can also be residual gallstones in the CBD. Yes, sir.
Okay, so if the patient has developed empyema of the gallbladder, how will you manage that scenario?
Uh, in empyema gallbladder, we can manage by giving we can manage the patient according to the CCRIS protocol, the A to E approach. We can start the patient with IV fluids and IV antibiotics. We can give analgesics for pain management. We can also give a high flow oxygen. And regarding the surgery, laparoscopic cholecystectomy is contraindicated. We should go ahead with percutaneous cholecystostomy and drainage of the empyema collection, followed by an interval cholecystectomy later after stabilization of the patient. Or if the patient is having any sepsis, because laparoscopic cholecystectomy will is contraindicated in such conditions, in empyema conditions.
Okay, great. So you did the session very well. So
Thank you, sir.
next we have the surgical feeding station. Okay, so this is your scenario.
Okay.
Kindly review it.
Okay. Okay. Yes.
Okay, so can you describe what the X-ray is showing?
Um, the In the X-ray, first we have to look for the air, then bone, then the shadows, cardiac shadows, then diaphragm, and to look for any effusion.
No, just tell
Here we
me
can
what abnormality you can appreciate in this X-ray.
looks like there is a gastric feeding tube which has coiled and is shown in the X-ray.
Okay. So what may
Yes.
be the cause of this in this patient?
Mm. Because since the patient is post surgery and before extubation, we have to put in the nasogastric tube and check. So if the patient received a tube after IELTS tube after the surgery, there will be difficulties in insertion of the tube leading to coiling.
Yeah. So what are the different feeding options available?
The feeding tube jejunostomy, total parental nutrition.
Okay, so what are the types of non-parental feeding?
The gastrojejunostomy, feeding tube jejunostomy, and gastrostomy feeding. PEGS feedings, PEGS tube.
So can you tell me about the advantages and disadvantages of nasovaginal tube?
Uh, the advantages are in nasovaginal tube. The patient will the tube is inserted through the nose. So the difficulty regarding the uh, aspiration is prevented. I mean, risk of aspiration is prevented. So the patient can be fed through the nasovaginal tube, as well as aspiration can also be done through the nasovaginal tube. The disadvantages are if the patient is having any facial abnormality, or in case of any facial injuries, the nasovaginal tube is contraindicated. We cannot insert through the nose. Um, it can also lead to trauma and bleeding.
Well, so what are the complications of enteral feeding?
Uh, if the patient has undergone any anastomosis, the early enteral feeding is not suggested until the anastomotic site is healed properly. This can lead to leakage of the anastomosis and any infection. It can also lead to aspiration, leading to aspiration pneumonia. Mm, if the patient is bedridden. Yes, sir.
And what are the complications of parental feeding?
The parenteral feeding, the venous access is done for parenteral feeding, so there could be risk of thrombophlebitis. There can also be fluid and electrolyte derangement, and also derangement in the iron, folic acid, and other electrolyte levels. So we have to check the values regularly, or in every 6 months. And there could also be a fall in the BMI, and the parental feeding can also lead to translocation of the gut bacteria, since there is no enteral feeding happening. Then we should also, there is also risk of DVT, and an embolus, so we have to give the TPN slowly.
Okay, so can you tell me what are the indications for starting TPN?
If the patient cannot swallow, or if the patient is having any stroke or requires prolonged feeding, if there is any anastomosis, or if there is any esophageal resection, in case of esophageal resections, then in proximal surgeries like esophageal surgeries, gastric surgeries, may need TPN.
And what are the different routes by which TPN is administered?
um, via the central line, through the internal jugular vein, or the subclavian vein, or the femoral route.
Okay, so what are the different type of electrolytes which are used in TPN?
Sodium, potassium chloride, magnesium, and phosphorus,
Okay,
and calcium.
so can you tell me what are the components of TPN and what is their percentage?
Mm, now I don't remember, sir,
Okay,
percentage.
so from which sources the energy requirements are met in TPN?
From the fat, and also from the uh, total energy in kilocalories, the carbohydrates, helps in maintaining the energy requirements.
Okay, So how much energy each of these components, that is the carbohydrate, fat, and protein, provide to the patient?
Fat provides 9 kilocalories. Proteins provide 4, and carbohydrates also provides 4 kilocalories
Okay,
per gram.
yes.
Yeah.
So what are the disadvantages of using glucose as the primary energy source?
Mm. It can lead to variations in the blood glucose value. It can also, if the patient is having diabetes, it can worsen, and it can also increase the body fat. If the patient is on insulin, the excess glucose is converted into fat and stored in the body. Um, so glucose is not yes, disadvantages, I think.
Okay. So in this scenario, first of all, you will be provided with the X-ray. So
Okay, sir.
basically, this is a nutrition surgical feeding type of scenario. So they want you
Okay.
to explain the X-ray. So you will say that this
Okay,
is
sir.
a chest X-ray, AP view, in which the NG
Okay,
tube
sir.
can be identified. Now, NG
Okay.
cannot be seen crossing the carina. It is above the
Okay.
diaphragm in the midline, and its tip is not present in the stomach. So
Stomach. Okay,
we
sir.
can conclude that this is not the safe time to commence the TPN or the
Feeding.
enteral
Okay,
feeding.
sir. Enteric feeding.
Yes. So regarding the feeding options, we primarily have two options. That is the parental and enteral. So
Okay, sir.
parental include TPN, whereas the
Mm.
enteral include various others. That is the oral, nasojejunal, nasogastric, PEG, and jejunostomy.
Okay, sir.
And then they will ask you about
Evening
the
surgery.
pros and
Okay, sir.
cons of different types. Like one is mentioned in this scenario, they can also test you for the PEG. Like it is used for long-term scenarios. Like if a patient is put for a long-term ICU care, then you will go with the PEG, that is the percutaneous gastrostomy, endoscopic.
Okay, sir. Okay, sir.
Now, whenever you define the complications of enteral and parenteral feeding, always divide them. Okay. So
Okay,
for
sir.
the enteral feeding, we can have it tube related and the feed related.
Okay.
Whereas
Okay,
for
sir.
the
Tube
parenteral,
blockage.
we are putting the
Okay.
CVP line. So remember that either it will be CVP line associated or food associated.
Okay, sir. Okay.
So in the enteral feeding, the tube can get kinked, misplaced, dislodged, it can get blocked. Whereas food
Blocked.
related could be nausea, vomiting, diarrhea, and it could be fluid electrolyte imbalance, liver dysfunction, and refeeding syndrome. Now,
Okay, sir.
regarding the parental feeding, the line associated could be hemopneumothorax, infection, sepsis, bleeding, and DVT formation.
Okay.
Whereas the feed related, which could be classified as metabolic, will be derangement
Okay.
of the fluid electrolyte balance, hyperglycemia, hypokalemia, and metabolic acidosis with hypercholelemia.
Okay.
So these are the different uh, complications.
Complications, sir. Okay.
Now, regarding the routes, CVP line and the peripheral inserted line are the best options.
Okay, sir.
Right. Yes. Remaining questions were like, okay, but the components include water, carbohydrates, fat,
Oh,
proteins, trace elements, and nitrogen.
okay, sir.
So this sums up our today's session.
Okay. Thank you, sir.